So shall I start, sir?
Yeah, please.
Yeah.
Good evening to all the respected teachers and my dear friends. So today the case for discussion would be on constipation. Initially, I'll be covering as a short case, followed by there will be some theoretical discussion on constipation. So let's start with the topic. So we had a patient recently in our wards. She's elderly, 70-year-old female housewife by occupation, residing in Coimbatore, and belonging to a socioeconomic status of higher middle class as per the modified Kuppuswamy classification. She came with the complaints of difficulty in passing stools, constipation since 1 year. So coming to the presenting complaints, she was diagnosed to have Parkinson's disease in last 1 year. And she started developing falls within that duration of 3 to 4 months. So she was diagnosed to have a Parkinson plus syndrome. She was on multiple medications for that. So she presented to us with a history of constipation, which was insidious in onset and slowly progressive since 1 year. Initially, she used to pass stools once in 2 days. Now it has progressed that she passes stools once in 3 to 4 days since last 3 to 4 months. And during that period, during which she is not passing the stool, she is having abdominal discomfort. But there is no abdominal distension as such. When asked about the consistency of the stool, she tells it is Bristol type 2, that is lumpy as well as sausage kind of stools. And she has to strain every time when she passes stools. Since last 1.5 months, she has been manually evacuating the stools. When she sits on the commode, she has to manually evacuate. She also gave a history that she has been using syrup lactulose in the beginning, which she took for about 2 to 3 months, about 15 ml per day at night. In that, her stool frequency slightly improved, but not completely improved. But she stopped it abruptly, thinking that it may have a lot of side effects as told by her treating physician. So when she presented to us, there was no symptoms of any unintentional weight loss or rectal bleeding, change in the form of the stools or the abdominal pain. So coming to her drug history, she was on levodopa and carbidopa since last 1 year. She is on amantadine 100 mg BD, flunarizine, and cogninon and Nurwire, which is a multivitamin for her Parkinson's, which is prescribed by a neurologist. So past history, no abdominal surgeries in the past. She had 2 children's normal vaginal birth was there, no cesarean section or no hysterectomy. Coming to personal history, diet, she's a pure vegetarian, consumes a good amount of fluids daily, 2 to 3 liters per day, a good amount of fruits also, and has a habit of consuming coffee for about 3 to 4 times per day. She says that appetite is reduced whenever she doesn't pass stools. So for example, once in 3 to 4 days, she passes stools. So in between that, the day she passes the stool, her appetite is good. But the next day, third day, subsequent days, the appetite comes down. She feels very much bloated up. She doesn't feel like eating anything. Sleep is adequate. Bowel, as told, irregular. Bladder movements are normal. And there is no family history as such in her family of this kind of constipation. So coming to general physical examination, she is
Anything else?
Yes.
Varghese sir, you think we should go to the general or?
I think he can analyze.
There are 2 discussants.
Yeah, there are 2 discussants. Let them discuss.
They want to discuss at this point of time?
Yeah, we will ask them to discuss. Who are discussing today?
Sir, myself, sir, Dr. Umar Sharif. I am from Gokul.
Dr. Umar, please discuss the case. You have heard the story, no?
Yes, sir. Yes, sir.
Can you just summarize
the previous slide? This patient is a 68-year-old female patient. If you can please go to the previous slide, Dr. Vishwas.
70 years, 70.
Okay. 70-year-old female. She was being a housewife by...
No need to repeat it. You just summarize.
Do you need any other history?
No, do you want any clarifications? Is this history enough for you? Do you want any further clarification?
No, sir, it's a...
No, you need some more answers in this. See, here is a lady who has been having constipation.
Yes, sir.
Progressively going up in the last 1.5 months, she needs So important thing we need to know is how many times she has to pass per day to clear her stools. Number one. Number two, does she have any feeling of incomplete evacuation? Okay, Vishwas has said certain things,
Yes, sir.
but here she has to manually evacuate. She has to strain. Other thing is she's 70 years old.
Yes, sir.
The questions you need to know is, does she always feel that she has incompletely evacuated? Or and how many times she passes to completely evacuate and to have a good bowel satisfaction. Number three, of course, Vishwas has said about the bleeding.
Yes, sir.
Number four, does she have any
Unintentional bleeding.
incontinence? So all these things are something which you should ask. Okay?
And regarding the laxative, which he has been taking laxative for the last 2 months, and whether with this laxative she is feeling okay, or is there a need to increase the dose of laxatives?
Lactase.
Because laxatives are not effective, whether she has changed the medicines using a different laxative, and whether that also requires a higher dose. Second, any additional maneuvering which is required apart from digital evacuation, whether she has to apply a lot of force on the lower abdomen or on the pelvis, etc. And any abnormal position also, posturing which she has to do
Change
it in
in
the toilet.
posturing.
Yeah. Whether there is a need to take enemas, because digitally they may evacuate and still they may feel unhappy or incompletely evacuated, so they may resort to self-enemas.
Daily
This is
enemas,
one thing
self-enemas.
which is done in most people with the pelvic disorders, especially dysenergic defecation.
Yes, sir.
Okay, we had a good drug history. Drug history is
But
very,
what
very
is
important. Yeah,
the
very, very
important
important.
thing is in an elderly constipation, history of drug is important. History of drug. In elderly patients, probably the drugs are one of the important causes of constipation. Number one. Number two, did she get any treatment? Was she any treated for hypothyroidism? Okay. Or does he have any features of hypothyroidism? Is something you need to take in the history.
Yeah, that was
That's also
required
useful.
positive mentioning, because nothing was there in the history, but we require a positive mention that there was no detection or treatment for hypothyroidism.
Hypothyroidism,
Because
and
it's
is she
very
a
common in the
diabetic?
community.
And is she a diabetic? What is the commonest bowel problem in diabetes?
Autonomic
Sharif. Huh?
Autonomic dysfunction, sir.
Now, what is a bowel? Is it diarrhea or constipation?
It's a constipation, sir.
Yeah, correct. Even though you're not noticing, the most common bowel, this thing is constipation, diabetics. So drugs, diabetics, hypothyroidism, any bony, I'm not saying suggestive hypercalcemia, all these things also. So metabolic problems also you need to discuss in these patients. Okay?
Yes, sir.
And as sir has said, you need to know the history of what is the history of the laxative use.
Yes, sir.
Was she taking OTC or was she progressing to something? Was she increasing the dose twice a day?
Yes, sir.
You said about the diminished caliber of these tools. What was in your mind?
Sorry, sir.
In which condition you get a diminished caliber of these tools?
In caliber of stools.
Because it is in the next somewhere you have mentioned it like that, no? I thought it was mentioned like that, no?
No, supposing the caliber of stools become thinner, what does it indicate, Vishwas?
Either she is overusing her laxatives, if she is using.
Or whereas caliber will come down.
Narrowing or obstruction.
Okay, you can have it in extremely severe situation like in neoplasm, but the stricture formation, or in thin caliber stools also it's very common in people with irritable bowel syndrome.
Irritable bowel syndrome. Correct.
Okay, the most common in the community will be irritable bowel syndrome, but in an elderly person with a recent onset, so that's the issues. In an elderly person with a recent onset of bowel symptoms in the form of constipation, you have to be very alert. Does it satisfy the criteria of IBS? Does this patient? Suppose I say it is IBS constipation.
No, sir.
Why? You have to tell specifically why not. First, it doesn't satisfy the criteria, no?
Yes, sir.
It does not
To
Because
satisfy the
diagnose
criteria.
IBS, actually, you should have symptoms for 6 months.
6 months.
Only
IBS-C
maximum
is,
for
what is the
4 months.
criteria according to the Rome? And IBS-C is constipation at least 3 times a week for 6 months
For 6 months.
and associated with abdominal pain.
Abdominal pain is
IBS-C will have abdominal pain. Idiopathic constipation will not have abdominal pain.
No pain.
Right?
Yeah.
Okay. So, Dr. Umar Sharif, can you just completely summarize quickly, and do you think what could be the differential diagnosis in a 70-year-old patient?
a
Umar,
70-year-old.
just to summarize the case
Yes, sir.
in 2-3 sentences and then try to tell us the possible.
Tell us what will be your
this is a
working
learning
diagnosis
exercise.
in your mind.
Yes, sir. A 70-year-old female patient who was recently diagnosed to have a Parkinson's plus syndrome on medication, developed a progressive constipation for the last 1 year, which aggravated for the last 1.5 months, which had made her to manuals such as manually evacuating the stools, and with a very minimal effect with the laxatives, with
No,
no
here
issue
is
in
a
weight loss and alarming symptoms like bleeding PR.
There is no bleeding PR, no?
There is
No
no
bleeding.
bleeding.
No bleeding PR.
So what I
No bleeding
understood
PR,
that
no
this
change in the
70-year-old lady
calculus,
has
no abdominal.
progressive constipation for the last 1 year and which is worsened for the last 3
Last
to
1.5
4 months, and there is a need to take laxatives with which she has got some degree of relief, and
And
she
the
gets
manual
abdominal
evacuation.
discomfort and diminished food intake during the days when she has no bowel movement. But when she has good bowel movement, she actually eats. Okay. There's no weight loss.
And
no,
there is a manual evacuation.
Yeah, manual evacuation. The history of manual evacuation.
Manual evacuation. So,
So what
she's 70-year-old age. She is on drugs for Parkinsonism. Number 2, she has constipation. She has got strain to pass stool. She has a manual evacuation, partially with lactulose, with no sinister symptoms. So, what are your differential diagnoses?
There was a question whether we should say the Bristol stool chart type. Well, if you are allowed to take the Bristol stool chart in the examination, we can definitely say.
You can take it. You can take it.
Because you just ask the skilled assistant.
Yeah,
Don't take it for granted. Ask them whether you will allow me to take it, and if they allow you, then obviously you have to say it. Otherwise, you have to say, as per the history, it apparently looks like that. You can also guess it also from the description.
After all, Bristol chart is 1, 2, 3, 4, 5, 6. That's all.
Yeah. I think there was one more thing in the history which probably we should have asked, because the female, there's a prolapse uterus and things like that. Because in females, pelvic floor dysfunction can also occur due to weak pelvis, and other signs of it will be a uterine prolapse or a urinary bladder prolapse, whether she has to push up the bladder for proper urination, whether there is a uterine prolapse, etc. That also history may be equally important in females that you have to elicit.
Yes, sir.
Okay, so what is it?
What is your differential diagnosis?
So, the patient itself have a she has an underlying condition called Parkinson's plus syndrome. So Parkinson's disease.
Doctor, we don't want. Just tell us what are the differential diagnosis in a 70-year-old Parkinson patient who has to strain to pass stools, manual evacuation, no bleeding, and a partial response. Number 1.
Slow transit constipation, sir.
What is when somebody does a manual evacuation? What will be your diagnosis first?
It's a functional defecatory disorder.
Defecatory disorder. So now it can be a defecatory disorder. Okay. Number 2. So it could be defecation, dysynergia, isn't it?
Pelvic floor dysynergia.
Yeah, it could be defecation, dysynergia. Number 2.
It could be IBS constipating type.
What is it?
IBS constipating type.
Well,
IBS constipating type. What did I tell you about between?
But no abdominal pain, no?
There is no. What is the definition of IBS-C according to Rome 4?
pain per day in a week with
No,
pain.
it should not correctly define, madam. Don't say that pain vaguely you said. What is the definition of IBSC? Find out and see what it is. It is how many times, or what is the duration of constipation? Before you say qualify somebody for IBSC by Rome Foundation. 6 months. How many days in a week they should be constipated?
In adults, at least 1 day per week.
Should have 3 days constipation for 6 months. And in IBSC, generally it is associated with abdominal pain. That is what the difference between chronic idiopathic constipation versus IBSC. Generally, they have abdominal pain, associated pain, which may get relieved. Kindly go back to Rome for Rome, IBS, Rome 4, and then come to the correct diagnosis. Okay, somebody has got, so it could be IBSC, but abdominal pain does not really classically come to the IBSC. It could be, what is the next cause, the most common possibility in this lady? Can be drugs, no? She's got Parkinson's, and all these Parkinson drugs contains anticholinergic drugs which can produce constipation. Very common. Okay. We don't see the discussants.
Neurology.
Yeah, can you switch on your
Switch
video?
on your thing.
Umar
We
and
don't see your
Shravanti?
there.
Who is the other
Who are the
person?
two discussants, no?
Shravanti.
Yes, sir.
Okay.
It could be
Who is the other one? Umar Sharif.
Umar Sharif. Okay, you said,
Please come on thing and let's see what we discuss.
can it be simply idiopathic constipation?
Yeah. Could it be chronic idiopathic constipation?
Elderly person, they are very vulnerable to develop all these things.
elderly age, female gender, it could be a possibility of idiopathic constipation. Because of her Parkinsonism plus disorder, it should be a neurologic constipation.
Parkinsonism commonly does not have any neurological involvement constipation. The most common cause of constipation is drug. In Parkinsonism is drugs. Despite dysautonomia, patients with Parkinson don't produce constipation, not because of constipation, because of drugs. So number one, it could be defecatory disorder. Number two, it will be drugs. Number three, you said IBSC, but does not really qualify. Chronic idiopathic constipation could be either slow transit or normal transit.
Can it be neoplasm?
Neoplasm. You should always
Elderly
consider
person,
a
70-year-old
neoplasm.
person, only 1
There's
year
no
history.
history of any
Can you
unintentional
consider
weight loss.
neoplasm?
There's no history of any unintentional weight loss or rectal bleeding.
Patient is already 70 years, so she may not be not really noticing. So another thing, I think I'll strongly suspect a neoplasm in these patients. Okay.
I think all elderly person, when they present very late in this pageant of, at 70 and all, one must be extremely careful. Even if it is typical of IBS, I think we should be extremely careful not to diagnose it straight away, because we would be missing an organic disease. So
yeah,
this age, probably we have to give importance to rule out an organic
neoplasm.
disease, a sinister disease like a neoplasm. Probably it may be less likely because neoplasm which would have manifested as constipation 1 year ago, and still she is getting relief. It should be very slow growing tumor. Otherwise, should have grown very fast and produced complete obstruction in such a period, 1 year, no? And no other symptoms like bleeding, no pain, nothing is there. Less likely, but sometimes patients may present totally atypically. So one cannot totally rule out on clinical history alone. So one is drug-induced, idiopathic we consider drug-induced, pelvic dyssynergia and neoplasm. Anything else? Shobhana ma'am, welcome.
Thank you. I'm just listening right now, and let them finish their differential. I have a few more to add.
Okay. Shravanti and Umar, do you have any further differential? Shobhana ma'am, can you?
So in Parkinson's, quite often they don't have a good diet. They may not notice their weight loss, and because they're not eating well, or they tend to eat more only soft substances, they avoid fiber because they just can't swallow well, and they become very slow. So, the activity has gone down and their food has gone down, but because the activity has also gone down, their weight they don't lose so much weight.
So much weight.
Yeah, so it's just a combination of both lack of activity and decrease in food. They don't lose so much weight. So sometimes it may be just that they are not eating well. And of course, all the causes that you mentioned are there. And I think what you said, Dr. Viti, that importantly that in these patients, we must rule out a secondary cause because this is a 70-year-old who for the first time has come with constipation. Secondly, try to find out whether they are edentulous at this time. You know, because at 70, many people have lost a few teeth and they start eating a very soft diet, just like in Parkinson's. Even just because of age, they may just eat some bread and something like that, which is not adequate and it does not form good stool at least. So that may be one of the things that we have to be careful about in a patient with constipation in the elderly.
Yes, ma'am.
Can we look at the physical findings?
Yes. She's moderately built and nourished, conscious, cooperative, well-oriented with time, place, and person. Sir. Weight of 60 kgs with height of 156. She has got a good BMI of 24.4 kg per centimeter square. There is no pallor, icterus, cyanosis, pedal edema, or lymph nodes. Pulse rate and BP are normal. So coming to systemic examination, per abdomen is soft, no tenderness, no organomegaly, no free fluid. Respiratory system is normal. Cardiovascular systems are normal. CNS, she moves all the limbs. Tone and power were normal. Deep tendon reflexes were exaggerated. Bilateral, there was flexor plantar response. We examined the spine also. Spine was also normal. On per-rectal examination, visualization anal tag were present and sphincter tone was increased on per-rectal examination.
Anything else to be mentioned on per-rectal examination?
Okay, yes, I think discussants, how will you approach this rectal examination in this patient? What are your steps of rectal examination
Inspection
in this
on,
patient?
Initially on inspection, you have to see for any external hemorrhoids and skin tags. And on palpation, we have to feel the tone of the
Hemorrhoids, skin tag, scars.
scars.
How do you know she didn't have any perianal abscess?
Yes.
When you have to look for
Then-
soiling.
Soiling, yes.
And you also look for a fecal soiling, isn't it? Patients with constipation, sometimes when they have evacuation disorders, can soil fecal. They'll be thinking they're having diarrhea, basically. They may have a spurious diarrhea. And inadvertently, they go to a practitioner, then they'll go and tell this patient has got diarrhea, but it's actually fecal soiling due to some sort of minor fecal incontinence. These people can have minor fecal or major fecal incontinence. So at that time, what happens? Sometimes they inadvertently take antidiarrheals. This is a very common situation. Then the constipation worsens and they land up in ER with severe abdominal pain. So these are things, very practical problems which will come.
Okay.
So you should
What
see
else?
whether there's any fecal soiling. Then what else? Palpation, what do you do?
Palpation, we have to feel the sphincter tone on palpation.
Before that, do you want to check the rectal sensation?
Yes, yes.
So you have to do the scratch reflux, isn't it?
Yes, sir. And then posteriorly, we have to feel whether the patient.
No, you're going to put the finger in. Where are you putting the finger in first in? How far you will put in? There are steps for rectal exam, madam.
Yes.
Especially in a patient who's got a constipation. So where will you put the first finger in? How much you will insert in? Every constipation, you should do a rectal exam. So you're going to put in a small finger inside to look for a sphincter tone.
Yes.
And just with the finger inside, you're going to ask her to contract and see whether
tone is normal.
Tone is normal, tone is increased. And you should also ask them to do an act of
Defecation.
Training.
When you do an act of defecation, normally what happens?
The finger moves up.
The sphincter tone relaxes. So if the sphincter tone contracts during the act of defecation, then you know it is dysenergia or hypertensive sphincter. Then you put the insert in, and what do you palpate?
Posterior wall, we have to
Pardon?
See for the tension or tenderness because of the increased puborectalis tension.
Okay, rest is.
So how do you find out the puborectalis is tense?
When the patient says she is
Actually,
having
you
pain,
should have posteriorly, anteriorly. Anteriorly, when they ask them to contract, you'll be able to, if it is very tense, you'll be able to feel the sling of the puborectalis and it will be painful. And then you should ask that, then how do you perform the act of defecation with the finger fully inside? What do you want to look for?
we have to ask the patient to strain.
You have to put your left hand on the patient's abdomen and ask them to
strain as
strain.
if they are doing defecation.
Yeah, as it strains, what are the things you look for? When your finger is inside, what are things you're looking for?
Descent of the finger, we have to see.
Yeah, you have to look for the pelvic floor descent.
Pelvic floor descent.
Is it
No, the
abnormal
pelvis,
or not?
not the finger. Oh.
Traction
For the
pressure.
pelvic floor descent, and then also feel the sling of the puborectalis over the thing. And of course, you should always feel for any presence of any growth or not. Okay?
Yes.
Yes, sir.
And in a female, you'll also look for pelvic deposits, or male. You look for pelvic deposits. At the same time, you feel for a rectal growth. Okay?
Yes, sir.
Yes, sir.
And when you take out the finger, what do you look for? Is there a blood in the finger stop?
Staining, fecal staining.
So if there is a severe descent and during the thing, and if the anal sphincter tightens during the straining, it will kind of straight away make a diagnosis of defecatory dysenergy or disorder.
Dysenergy.
DT sir and Shobna madam, you want to add on anything in the
Yeah,
rectal examination?
definitely. So with the rectal examination itself, one may get a clue that we are dealing with the pelvic dyssynergia. Of course, you have to do all this all this tests properly, and only you'll be able to do, and you should on a regular basis. Because if you are doing it for the first time, you may not know whether it is right or wrong what you are getting. So on a regular basis, whenever you have a patient, you have to practice this, and then only you will be able to understand the significance of these findings. Okay. So physical examination, we have probably anal tag, finger tone increase. Other than that, in the examination of abdomen in a patient with the chronic constipation, one should also look whether there is a lot of fecal masses, chylous masses, etc. Sometimes you may be able to feel in the distended colon, so you may be able to palpate it, etc., etc. So one may look for that, and one may also get some masses which could be indented by pressure. Okay, so these are my additional findings which you may get on physical examination. So after physical examination, we have not become much wiser.
One more thing. This patient is a case of Parkinson's disease. So at least mention some signs of Parkinson's if they are there, especially in a long case. And if the Parkinson's signs are not there, then try and see when the patient has had their medications. If the patient has had an early morning syndopa and at about 9 o'clock when you examine, there may not be any gross signs. So remember to mention that. Ask the patient when they had their last medications, and that is why the tremors and all are not there. So that gives additional, that you have taken this patient history.
Yeah, that's a good point. That's a very good point. Okay, so after physical examination, we have not become wiser. Let's stick with our first diagnosis, no? So we'll have to investigate. But then should we continue with the approach and then finally come back to the case? Vishwas, how are you going to proceed?
Sir, next will be the investigations. What investigations we did, sir? Then,
Shall we ask the presenters how they investigate?
sorry, sir.
Umar,
Sir.
how will you investigate?
So
Just briefly.
First, I would like to get the basic blood counts.
Okay.
I want to get our TSH calcium levels.
Thyroid profile, calcium. Okay.
Yes, sir. And
what next? Anything else, or you stop at this level? There were few diagnoses which we mentioned, no? Like idiopathic constipation, drug-induced constipation, possible pelvic floor dyssynergia, and possibility of neoplasm to be considered and ruled out. So these are the 4 things. So do we have positive diagnostic test for each of these?
Yes, sir.
As per the AGA criteria, what flow, or how do you plan the investigation?
Anorectal manometry, sir, because the patient anorectal manometry.
Okay. Why do you want to do anorectal manometry? What will you find out?
So this patient already history and examination wise, she's having this increased sphincter tone upon digital rectal examination. So possibility of a pelvic floor dyssynergia is definitely
high. Yeah.
Yes, sir. So anorectal manometry will definitely identify if the patient has a pelvic floor dyssynergia.
Okay. Okay, one is that. Anything
Can I
else?
Here,
Yeah.
can I ask a question here?
Yes,
When you plan your investigations, you usually plan that you want to rule out the serious organic diseases first.
Yes, ma'am.
Okay. So
Yes,
in your differential diagnosis, one of the things I actually forgot to mention earlier is hypothyroidism is an important differential diagnosis first onset.
Yes,
because if the patient is 70, many things may not be noticed. Constipation may be the only history. So whenever there is such a case, you got 4 or 5 differentials. You decide which is either the most common likely or the one which is most serious and likely to have a bad outcome. So you would always investigate that first.
Yes, ma'am.
Okay. So now go back and think which investigation would you like to do first?
No, I would like to rule out hypothyroidism first.
Yeah, that we already mentioned.
Yes, sir.
Next.
Any electrolyte abnormalities
Like
hypokalemia,
No, all those things we ruled out. Okay. Next.
The ICU. This patient is in the OP. So hypokalemia and all that are less likely.
Are they unlikely? No, hypercalcemia maybe.
Hypercalcemia may be
both
there.
you have mentioned. What else? Next. Because one of the differentials which you considered was the neoplasm. No?
Neoplasm. So what do you do?
How will you rule it out?
Well, if I have to rule it out, I have to do a colonoscopy.
Yeah.
Okay. So you don't have to be shy about it, because if you want to roll out a neoplasm,
No, but you have to do
unless you do a
colonoscopy.
proper procedure, you won't be able to do that. No.
Yes, sir.
And once you roll out a neoplasm, well, then next will be to identify the pelvic floor dyssynergia or other forms of motility disorder whatsoever it is. Because with a neoplasm sitting in the left colon, and if you go and try to do pelvic floor dyssynergia diagnosis and all, finally there could be some abnormalities and you'll be totally off the track.
Yes,
okay,
sir.
so that should
Yes,
not happen. Okay, agreed. Colonoscopy, then colonoscopy negative.
Then what do you do?
Manometry. And if anorectal manometry is negative, what will you do?
Well, I'll treat
What will be
her.
the next test?
So you do a blood investigations, you do a metabolic profile, colonoscopy is negative. She has been having fecal evacuation. She does a finger evacuation. So what do you expect in the anorectal manometry?
Do you expect it to be abnormal or normal in this
Normal.
patient? Because from history, actually, we could diagnose the pelvic floor dyssynergia because
supposing
of
her rectal exam has shown there's a hyper and sphincter tone is increased.
Yes, sir.
There was anismus and there was a more than 5 centimeter pelvic floor descent. So what are the investigations you like to do in this? She's a lady. What will be the next 3 investigations you will do? So in anorectal manometry, what will you find? What are you going to look at the anorectal manometry?
So the rectal continence and external anal sphincter tone.
No, you're going to look at the
recto-anal gradient.
What are the various components of the test?
Baseline rectal pressure,
Baseline
sphincter tone, What will be the squeeze pressure?
Pressure, rare response.
Rare is there or not. And then you will find what will be the
Maximum tolerable
during
volume.
during straining, what will be the fall in rectal pressure and increase in and fall in anal pressure.
Fall in the anal pressure.
These are things you need to look for. And you will also do, apart from anal electrometry, what else you will do?
Balloon expulsion test.
Balloon expulsion test. Can you tell about the balloon expulsion test, madam?
Yeah, patient is placed in left lateral position and 50 ml.
Can you come on live, madam, please? You ought to be alive before you talk. It's like an exam.
Patient has to be lying in the left lateral position.
Have you done a balloon expulsion test?
Yes, sir. In our practice, we are doing it in lying position along with the anal manometry test. We'll be installing 50 ml water into the balloon, and then we will be asking the patient to strain to expel out. And the duration taken to expel, we are calculating. Usually, it will be less than 1 minute.
And you'll also check what will be the rectal sensitivity at what level of this thing. If rectal is not at 50, you go to 100 like that.
First
You look at what will be the rectal sensitivity of feeling the expansion of the balloon.
First sensation at what volume, and the first get the volume and the maximum tolerable volume. These volumes will be measuring by successively increasing at 50 ml, at 10 ml, 10 ml, 10 ml.
Okay. So what do you expect in this patient?
In this
sphincter
patient,
tone is increased.
So one is increased sphincter tone. So negative rectoanal gradient I will expect. That is increase in anal tone in contrast to fall as I increase the rectal pressure. And
Do
then
you have a
could be
classification, anometric classification of defecation dysynergy? Type 1, type 2, type 3.
5 types are there.
Vishwas, are you covering all these things? Vishwas, in your presentation?
Vishwas, you can go ahead with your presentation.
Yes.
Okay, I think for completion's sake, a difficography may be required, MR difficography.
Yeah, after this, MR difficography needs to be seen. And in a female, we should always get a good gynecological examination, as sir said, to rule out a uterine prolapse. Sometimes there can be a gross prolapse which is causing, and just correction of this uterine prolapse will do the problem. So do you have any rectal prolapse? So next can be MR difficography. Ideally, MR difficography has to be done in a sitting position, but we hardly do it. And regularly, I think we should, most of the times in MRI, they do it in the left lateral position. That's not right, actually. The best is always to have to do a difficography. You have to create a difficography unit and then kindly do it. So MR difficography may not always be very correct, because everywhere they do it only in they should do it in a squatting position. And in a female, I think I'll always do a good gynecological examination, ask the gynecologist to see to ask whether there's any UV prolapse, uterovaginal or uterorectal prolapse. Shobana madam, you want to add something, ma'am, in this?
No, not really. I think they've covered everything. But yes, after the colonoscopy, all these tests are to be done. Now, one thing is that though, like you said, the left lateral is the one that we all use, but it should be in the sitting position.
Yeah.
Patients are not able to squat, so you have to provide a special chair with the balloon down. And it is not essential to have the manometry machine attached when you're doing the balloon expulsion test. You have to only record whether the patient is expelling the balloon or not.
Or not, yes.
So that is according to the London classification. And all residents should read this London classification.
London's classification.
Yeah, it is available for free. The first author is Carrington. Carringtonmre. Okay. And then you can look at it. So that may be one. Gynec examination, of course. And then see if there is anything else. Because 70-year-old, I'm not happy that this patient has, you're diagnosing as dyssynergia. I'm still not happy. Okay. Let's continue with the presentation. Yeah.
Colonoscopy is normal.
So we evaluated with the blood test. All the blood tests were normal, including cortisol, TSH, HbA1c, and ionized calcium. Then we went ahead with the ultrasound abdomen with minimal sludge with urinary bladder wall thickening was there. Then colonoscopy was done. She had a long loopy colon, but no mass lesion was seen. Endoscopy was normal. Then we went ahead with the high resolution anorectal manometry. But the conclusion, this is how it is read: step 1, step 2, step 3, and step 4 as per the London classification. First is disorder of rectoanal inhibitory reflex. Then we look into the disorder of anal tone and contractility. Then third will be disorder of rectoanal coordinations, and fourth will be disorder of the rectal sensation. If you can see the first column, anal tone and contractility, anal resting pressure is normal usually. The value for her is 66 millimeter of mercury. Normal it is 35 to 100 millimeter of mercury. So up below that, you can see the anal squeeze pressure. Actually, there is something called short squeeze as well as long squeeze. Short squeeze is usually for 5 seconds, and long squeeze is usually for 20 seconds, and followed by pressure during cough and anal canal length. So some of these things are calculated by the machine itself. So coming to this rectoanal coordination, balloon expulsion was also normal, and time to expel balloon normal is less than 1 minute, and as the age progresses it may increase, but in her case it was only 14 seconds. So rectal pressurization during the push was reduced, and anal relaxation during the push was normal. So RAIR, actually it was normal. And when we did a rectal sensory testing, there was a hyposensitive rectal sensation. So based on the London classification, after going to that to the flow chart, the conclusion was she has a rectal hyposensitivity. And classify as per the part 4 classification, when we looked into her anal tone and this one contractility, the conclusion was like normal expulsion with abnormal manometric pattern of rectoanal coordination. Those flow chart, I'll be displaying it in the next when I discuss about the topic proper. So now it is not very clear whether it is purely due to, is it a slow transit or is it a defecatory disorder. So next plan would be to do a MR defecography, which could not get it done. We are planning to do it in the OPD basis.
Can we go ahead with your presentation?
Yes. So the final diagnosis, so Parkinson plus syndrome, hyposensitive rectum.
But do you have evidence to say it is low transit? Because we have not
Not
done
yet,
a market
not
study.
yet.
Not yet, sir.
Not
Yes.
yet, no.
Not yet, yes.
We had to do a
Defecate.
transit study. We didn't do a transit study on it.
We didn't do a transit studies. We didn't do a transit study.
Okay, we'll start the presentation then.
Yes. Coming to the constipation, so this constipation is a word which can be referred in different ways by different people. It is some people refer hard stools as constipation. Some people with difficulty in defecation would refer it as constipation. So coming to chronic constipation, anything more than 3 months, 3 consecutive months is defined as chronic constipation. Usually chronic constipation is due to a disorder of colonic propulsion and rectal evacuation. There are 3 types, that is slow transit constipation, normal transit constipation, rectal evacuation disorders. So as per the Rome 4 criteria for the functional constipation, these are the criteria. So it should include 2 or more of the following. One is straining should be there for more than 25% of the defecation. Lumpy or hard stool should be there for more than 25%. Sensation of incomplete evacuations for more than 25% of defecation. Sensation of anorectal obstruction or blockage, and manual maneuvers, that is digital evacuations, and fewer than 3 spontaneous bowel movements per week. We had many of these things in our patient. And loose stools are rarely present without the use of laxatives, and insufficient criteria for the IBS. And criteria, it should be present for the past 3 months with the symptom onset at least 6 months prior to the diagnosis. This is the recent Rome 4 criteria for constipation. So prevalence is about 14%. The incidence of constipation is 17.4%, higher in the women, 18.3, when compared to that of the men, which is about 9.2. So some of the risk factors for constipation, one is advanced age, as we know. Women, quite common due to progesterone, high progesterone level, low level of education, low socioeconomic status, medications, as I told, mainly anticholinergics. I'll be discussing it further, and family history of any constipation. Some of the common causes of constipation, we can broadly divide it as mechanical, drug-related, metabolic, or neurological. So mechanical, we know colorectal carcinoma, that if there is any extrinsic compression, rectocele or a sigmoidocele. Drugs, calcium channel blockers, most common as antihypertensives, tricyclic antidepressants, anticholinergics, especially if you are using any ipratropium bromide as an inhaler in the elderly patient, we have to be very careful. NSAIDs, opioid agonist, and anticonvulsants. Some of the metabolics, most common cause would be diabetes mellitus, hypothyroidism. Hypokalemia is also one of the cause. Hypercalcemia is known to cause. Heavy metal poisoning. Hyperthyroidism is also contributing to constipation in some patients. Neurological, Parkinsonisms, dermatomyositis, amyloidosis, autonomic neuropathy, Scheidegger syndrome. So coming to this three types, first type would be normal transit constipation. In normal transit constipation, stool travels along the colon at the normal rate. Patient with normal transit constipation may have misconceptions about their bowel frequency and often exhibit psychosocial distress. So patient have abnormalities of the anorectal sensory and motor functioning, indistinguishable from those in the patient with slow transit constipation. So slow transit is most commonly seen in young women. They have an infrequent bowel movement, less than one bowel movement per week. The onset of symptom is gradual and it occurs usually at the age of the puberty, and it arises mainly due to colonic motor function problems. In patients with more severe symptoms, the pathophysiology includes delayed emptying of the proximal colon and fewer HAPCs after the meal. So colonic inertia is also a term used to describe the disorder in patients with symptoms at the more severe end of the spectrum. So defecatory disorder. This is rectal evacuation disorder arises from the failure to empty the rectum. This is mainly due to incoordination between the abdominal muscles, rectoanal, and the pelvic floor muscles. And many of these patients with a defecatory disorder have a slow transit constipation. So the other terms for defecatory disorders would be anismus, dysenergia, pelvic floor, spastic pelvic floor syndrome, obstructive defecation, defecatory. These disorders appear to be acquired and may start in childhood. There may be a learned behavior to avoid discomfort associated with passage of large hard stools or pain associated with attempted defecation in setting of active anal fissure and inflamed hemorrhoids. So individuals with defecatory disorder commonly have inappropriate contraction of the anal sphincter when they bear down. And patient with rectal evacuation disorder may repeat infrequent bowel movement, ineffective and excessive straining, and used for manual disimpaction, especially in the pelvic floor dysfunctions. So this is mainly for this defecatory disorder, the Rome-4 criteria, functional defecatory disorder. So the patient must satisfy diagnostic criteria for functional constipation or IBS with constipation. During repeated attempts to defecate, there must be features of impaired evacuation as demonstrated by two of the three tests below: abnormal balloon expulsion test, abnormal anorectal evacuation pattern with manometry or anal surface EMG, and impaired rectal evacuation by imaging. This should be present for previous 3 months, with the symptom onset for at least 6 months prior to the diagnosis. So some of the systemic causes, we as discussed previously, hypothyroidism, diabetes, and hypercalcemia, most common. Neurological would be Parkinson's, multiple sclerosis, and spinal cord lesions. Structural disorders of the colon, myopathy affecting the colonic muscles, hereditary internal anal sphincter myopathy, systemic sclerosis, muscular dystrophy. And some of the medications like NSAIDs, calcium supplements, antidepressants, can also cause constipation. Fecal impaction is quite common, especially seen in the elderly patient and also in the case of the children. There is a large mass of stool in the rectum of the colon that cannot be evacuated and usually presents as a complication. So lack of fiber and water intake and obstructing a lesion of the colon can be the cause for this fecal impaction. And the neurological cause like spinal cord injury or the neuromuscular diseases. Some medications also may contribute to this. So some of the problems associated with would be intestinal perforation, intestinal obstruction, circular ulcers, rectovaginal fistula, megacolon ulcerations. Digital evacuation, anemia and laxatives are one of them. So how do we approach the patient with constipation? So we ask into the duration of the symptoms. What is the frequency of bowel movements? Whether there is any abdominal discomfort, distension. What is the consistency of the stool? The degree of straining during defecation. Then is there any red flag symptoms like unintentional weight loss, rectal bleeding, severe abdominal pain? Is there a family history of colonic cancer? Drug history, dietary history, and any other metabolic disorders. Physical examination, again, for signs for the systemic diseases, for hypothyroidism, diabetes, then CNS patient with the paraparesis, stroke, Parkinson's disease, examination of perianal area like scar or fistula, then direct rectal examinations. Then we also look into the perineal descent in the left lateral position to look for any descending perineal syndrome. So some of the tests are tests for the systemic disease, as I told and covered in our case, test for the structural disease and physiological measurements. So these are the basic tests, most commonly calcium then sugars, diabetic to rule out diabetes, and thyroid function test. Then imaging modalities, CCT abdomen, MRI abdomen, MRI defecography, barium enema, and colonoscopy to rule out any obstructive lesion of the intestines. So, some of the studies which can be radio-opaque markers, colonic transit study which we do is, radio-opaque marker is used to distinguish normal from the slow transit constipation. In our hospital, we usually use capsules, 2 capsules every 12th hourly. So, 2. So 6 capsules will be given. Each capsule will be loaded with 10 radio-opaque material. So 2 capsules every 12th hourly will be doing. So after that, after finishing the last 2 capsules, 24 hours from the last capsule and 48 hours after the last capsule, we will take the X-ray to look for what kind of a colonic transit is there. And the main prerequisite for that is we have to avoid laxatives, enema before doing this kind of the test. And the colonic transit times would be ideally 30 to 40 hours with an upper limit of 72 hours. And usually women have got longer maximal colonic transit times than men. That is about 70 to 106 hours compared to 50 hours in the case of the male. So coming to next slide. This is one of the X-ray showing retained radio-opaque material, radio-opaque rings even after 120 hours of administration of this radio-opaque material. So next, wireless motility capsule. So it is usually a single-use capsule that assists the colonic transit without the radiation exposure. The main advantage of this is the gastric emptying time, colonic emptying time also can be known with the single-use capsule. The another advantage is it has got multiple sensors, so you can detect the temperature, pH, and pressure measurements. And the patient wears a data receiver on their waist for about 5 days, and it continuously records the daily activities such as sleep, meal, and the movement of the capsule within the intestine. The normal colonic transit time using the wireless motility capsule is about 10 to 59 hours, with the delayed colonic transit considered greater than 44 hours in men and 59 hours in the case of women. So this is the photo of the capsule. You can see the pH sensor. It has a battery. It has got an antenna. It has a temperature sensor there, and it has got a pressure sensor. So this is the reading of the wireless colonic capsule. So, the one more, we use radioactive material for colonic transit for determining the time. So indium is used here, IN 1111, labeled diethyl nitramine pentacetate with the standard egg sandwich indium labeled activated charcoal particles. So technetium, it helps in knowing about gastric, small bowel, and the colonic transit. And activated charcoal indium helps in knowing about the colonic transit. Echography, rarely done nowadays. The patient sits on a radiolucent commode, and the fluoroscopy, fluoroscopic images are taken during this procedure. Rectocele, if it is present, it feels preferentially. Then balloon expulsion test, as I told, with the 50 ml of water-filled balloon from the rectum. The test is generally performed while patient is sitting on a commode. Abnormal in patients with pelvic muscle dyssynergia. And usually the duration increases as the age increases. So anorectal manometry, to know about the maximum squeeze pressure of the anal sphincters. A high resting anal pressure suggests the presence of an anal fissure or the anismus. A patient with defecatory disorder commonly have inappropriate contractions of the anal sphincters. And positive rectoanal gradient, higher rectal than anal pressure is generally thought to be necessary for normal defecation, whereas a negative rectoanal gain is associated with the defecatory disorders. So this is a high resolution anorectal manometry which was done in our patient. So we use a London classification, and they have four London classification type 1, 2, 3, 4. So first we'll be seeing into the rectoanal inhibitor reflex column. Then we go into the anal tonal contractility, then disorders of rectoanal coordination and disorders of the rectal sensation. Based on that, we do the final reporting. See anorectal manometry. Rectoanal inhibitor reflex not elicited. Yes, then it is rectoanal areflexia. If it is no, then it means that there is no disorder of the rectoanal inhibitor reflex. Here, rest and squeeze pressure. Anal resting pressure more than the upper limit of the normal. That will be given, the upper limit of normal, the values will be given by the machine transducer itself. So it is more than the upper limit of normal, as we know, it is anal hypertension. If it is not, then we anal resting pressure less than the lower limit of the normal. Yes, then anal squeeze pressure is done. If it is less than lower limit of normal, then it is combined anal hypotension and hypocontractility. If no, anal hypotension with normal contractility. If anal resting pressure less than lower limit of normal, it is not less than lower limit of normal, then we go ahead with the anal squeeze pressure less than lower limit of normal. Yes, then it is anal normotension with hypocontractility. No means no disorder of the anal tone and contractility. That is step 1 and step 2. Step 3, we do something called abnormal balloon expulsion test. If it is present, its rectal pressure increases during the push greater than the upper limit of the normal. Then anal pressure decreases during the push greater than the upper limit of the normal. Then we go ahead with then it is known as abnormal expulsion with a normal manometric pattern of the rectoanal coordination. If it is no, then abnormal expulsion would be synergia. If the rectal pressure increases during the push greater than the upper limit of the normal, that is not there, then anal pressure decrease during push greater than upper limit of normal. Yes, abnormal expulsion with poor propulsion. If it is no, abnormal expulsion with poor propulsion and dyssynergy. If none of this pattern is seen, then it is normal expulsion with the abnormal manometric pattern of the rectoanal coordination. Our patient had this thing. Lastly, we look for the rectal sensory examination. Rectal sensory test would be if greater than or equal to 2 out of the 3 sensory parameters more than the upper limit of the normal, then it is rectal hyposensitivity. Then 1 or more sensory parameters less than the upper limit of normal, then it is rectal hypersensitivity. So our patient had rectal hyposensitivity, normal expulsion with abnormal manometric pattern of rectoanal coordination. So overall, coming to this algorithm, how do we manage a patient with constipation? So history and physical examination is very important, followed to rule out any secondary causes, the metabolic causes of constipation. Then we increase the fiber intake at least 20 grams per day. If there is inadequate response even after the fiber intake, then pharmacological treatment would be started. Stool softness can be started. Then go ahead, if there is an inadequate response, go ahead with the anorectal manometry. balloon expulsion test. If it is normal, then we go ahead with the colonic transit study. That will help us in differentiating between the normal transit constipation and slow transit constipation. If it is abnormal, then it means a defecated disorders. Then the next would be defecation training, a psychological consult, all those things. If it is inconclusive, then we go ahead with the MR defecography. So some of the treatments, that is general measures, specific medical therapy, other therapies and surgeries. So general measures, as all we know, lifestyle changes, more physical activity, more fluid intake, high fiber intake, and low food diet. So coming to fiber, most commonly we use isabgol. It is derived from the husk of plant, mainly grown in India, has got a high water binding capacity. And it is fermented in the colon to moderate extent and increases bacterial cell mass. So there are other things which are less commonly used. So coming to osmotic laxatives, the poorly absorbed ions, magnesium sulfate, phosphate ions are poorly absorbed in the intestine, and they create a hyperosmolar interluminal environment. So some of the poorly absorbed sugars are lactulose, which we commonly use. The bond in the lactulose doesn't allow to be broken by the lactase enzyme, so it reaches the large intestine, where fermentation occurs by the colonic bacteria into short chain fatty acid, hydrogen, and carbon dioxide. That helps in reducing the pH in the colon. Polyethylene glycol were very commonly used. It is also an isoosmotic laxative that is metabolically inert and able to bind to water molecules, thereby increasing the intraliminal water retention. PEG is not metabolized by colonic bacteria, and PEG is actually helpful in chronic. It is proved to be beneficial in idiopathic constipation. One of the side effects being nausea. Nausea is quite significant in patients taking polyethylene glycol, and it is excreted mostly unchanged in the fecus. So stimulant laxatives, anthraquinones, very rarely used nowadays. It is poorly absorbed in small intestine, so it reaches the large intestine and produces its action. But pseudomelanosis coli is one of the problems with anthraquinones. Castor oil rarely used nowadays. So stimulant, we commonly use biscodyl and sodium picosulfate. Biscodyl and sodium picosulfate are hydrolyzed to the same active metabolite. Biscodyl is hydrolyzed by intestinal enzymes and thus can act in small and large intestine. Phenolphthalein, again, not used. Biscodyl is, the dose would be 5 to 10 mg, and sodium picosulfate, it would be 10 mg. Stool softeners, dioctyl sodium sulfosuccinate is available as a stool softener. But further studies are required to look for its efficacy, and the compound stimulates fluid secretion in the small and the large intestine. Mineral oils, again, not commonly used. Enemas, we have also phosphate enemas, which are hypertonic enemas. Stimulant enemas like glycerin enema, the effect is mainly caused by the osmotic effect. So the newly used, new in the market constipation medications are this chloride channel activator, lubiprostone. It is derived from the prostaglandin E1, and it acts on the small intestine as well, on the intestinal chloride channels. So there will be a lot of chlorides moving into the lumen of the intestine, followed by water as well as the sodium. So causing intestinal fluid secretion and acceleration of the transit. And the dose would be 8 microgram BD, which is used. Guanyl cyclase agonist, it is minimally absorbed 14 amino acid peptide that activates the guanyl cyclase C receptors on the luminal surface of the intestinal epithelium, resulting in increased level of cyclic guanosine monophosphate and increased secretion of chloride and bicarbonate into the intestinal lumen. Dose would be 145 microgram once daily and subsequently 72 milligram daily. Plicanatide is a newer congener, same as that of the linaclotide. The dose would be 3 mg per day. Rucalopride is one of the things which is commonly used. Benzofuran derivative accelerates colonic transit in healthy humans and patients with chronic constipation. Dose is 2 or 4 mg once daily. It has no CVS side effects. Tigasteroid, it was approved once upon a time, but it is known to cause long QT prolongations. It is actually a partial agonist of IST4. Some of the newer tenaprenor is a sodium hydrogen exchanger 3 inhibitor approved for IBS-C. cholinergic agents, more of theoretical, not much used. Botulinum toxin, which has been tried in constipation. Some of the future agents, ilobixabat, is a investigational. It is a minimally absorbed ileal bile acid transporter inhibitor that increases flow of bile into the colon, causing loose stools. Quinodeoxycholate, Velustrag, and Relamorelin, which is a ghrelin agonist. It accelerates the colonic transit. So some of the other methods, one is defecation training. It usually involves about 3 to 5 treatment sessions. There will be a listener, I'm a sympathetic listener to hear the problems faced by the patient. During the session, the normal defecation process is taught and misconceptions are actually dispelled. Because as there is a empathetic listener, this has a lot of psychological benefit for the patient who has been suffering from this kind of problem for a long time, and they feel it humiliating to discuss it in the with everybody regarding this kind of problem. So coming to anorectal biofeedback, during anorectal biofeedback, which typically follows defecation training, patient receives visual or auditory feedback or both on functioning of his or her anal sphincter and pelvic floor muscles. Biofeedback can be used to train patients to relax their pelvic floor muscles during straining and to coordinate the relaxation with abdominal maneuvers to enhance entry of the stool into the rectum. And it can be performed with an EMG or anorectal manometric catheter. The complementary medicine like probiotics, Bifidobacter animalis and fructo-oligosaccharide is in the study shown to improve the bowel frequency and consistency and decrease the straining. Sacral nerve stimulation helpful for the patient with severe constipation who failed treatment with the laxatives, suppositories, and enemas. It is done with a temporary stimulation wire connected to an external pulse generator. Surgery is a large treatment when all the medical treatment has failed and there are severe patient is having obstruction due to severe constipation. Mainly it helps in relief of the abdominal pain and distension, ease of defecations. So some of the surgical procedures which are followed are colectomy, which can be done for slow transit constipation with normal defecatory function. Then stoma is done. It is reversible. Ileostomy is performed. One of the new procedures that stapled transanal rectal resection STAR procedure has been used with some success, particularly for the patient who also have a rectocele and intersusception. Puborectalis or internal anal sphincter muscle division is unsuccessful in patients with slow transit constipation. Thank you.
Just want to make a comment on that soaps and enema. Soap water enemas are not to be used anymore.
Not to be used.
Because soap is now found to be dangerous and it can produce severe chemical colitis. So it was an old fashion and we had actually published a series on soap water enema induced colitis. So in olden days when we were students and all, this is a routine practice, especially in obstetrics, before delivery and all they used to give. And after delivery, they used to develop features of proctitis, colitis, etc. So soap water enema is not to be given at all.
What is the algorithm of pharmacotherapy? Which one you will recommend first in a patient who, supposing we have something like, say, slow transit constipations or idiopathic constipation? Which are the drugs which you can recommend as a first line?
First line would be polyethylene glycol, sir.
Yeah, polyethylene glycol is the
Glycol
first.
is
If
very
you look at the pharmacotherapy of idiopathic constipation, I think polyethylene glycol can be given twice a day, but you need to give it in about 250 ml of water.
50 ml.
And duration?
We can use it up to 3 months, sir.
4 to 12 weeks you can use it. The other drugs which you can use are sodium picosulfate bisacodyl. Probably these three are one which you are generally recommend to use. And here you have not mentioned Senna is also recommended. Soft Senna, which is a thing, is also recommended. And among that, lubiprostone, I think we need to go up a little higher dose, 24 mics twice a day. You can give up to, their recommendation is 12 weeks, but they have not really mentioned how many days you can give it in the drug profile. Probably you can give it for a long time. Linaclotide is not available. Some of our patients got it from Singapore. We have no, Proclopride, of course, you sue, but Proclopride can the maximum dose you can go is about 2 milligrams once or twice a day. Don't go in elderly patients because that also can produce some sort of syncope on all these patients. And of course, majority of our patients, we think in our place, most of them are defecatory disorders. And we put them on biofeedback with a visual analog for at least 3 months. When you have a defecatory disorder, don't ever recommend this bulk laxatives like Natural Lax or Xylem. You don't use the recommend because already they have a defecatory disorder. So you don't really recommend bulk laxatives in these patients. Dr. Varghese sir, Shobana madam.
We actually long back did a study on because in India we find males with constipation more, especially IBS, unlike in West where females have this constipation issue. So long back we did a study on the role of tegaserol. It's a randomized controlled trial in males, and it is published in Journal of Gastroenterology and Hepatology. And we found tegaserol to be quite useful and not much of side effects anyway. But sooner or later, tegaserol got out of market, and now it is on restricted prescription only.
He has done a very good job of the review. Just a few quick comments. One is that in the causes of constipation, drug-induced, though this patient had Parkinson's, we should never forget that there are certain drugs used in malignancies which can cause very, very severe constipation, and we should not forget that. The second thing is that lactulose should not be used if the patient has any degree of gas bloat or SIBO. The gas bloat just gets worse. They have terrible bloat after that. So those are the few points that I had. Otherwise, I think he's done a very good job.
Even the fiber supplement, we don't recommend more than 20 grams, no, madam, because of bloating.
No, not only that. I think because the thing is that with fiber, if you look at a study done by the AIMS group many years ago, they found that the Indian diet, especially the vegetarian diet, there is enough fiber.
Enough fiber.
Yeah, but what you tell them to avoid, tell them to avoid a few things. Tell them to avoid these refined flours like maida and bread and biscuits and all these, salted snacks. That causes a lot of problems. So that is one. Secondly, like I said earlier in the patient, in an old patient, also check out their teeth. If they cannot chew properly, they will swallow some things whole. Yeah. And that may also cause problems. Sometimes they'll end up getting food impactions because of, fruit which may just get impacted somewhere. So these are things to consider before we start putting them on any kind of specific therapy. And it's more of a social visit that we have with them quite often, just explaining to them the diet, things like that. And one more thing is that in patients who are using the Western toilet, the Indian toilet is perfect for defecation. The Western toilet is not.
People have stool in.
No, when you're sitting down, the best position to defecate, to get the anorectal angle to straighten out, is when the knee is above the hip. Okay, so that happens in squatting, but does not happen in the Western toilet. Western toilet, the knee is hanging. Yes. And therefore, there are these devices called as poop stools, which are available in the US at a very high cost. For our patients, what we tell them is to buy our ordinary plastic stool.
Yes.
A plastic stool, and keep the feet on that in such a way that the knees are above the hips. And that changes the angle, and the patients have a lot of relief just because the effort is more fruitful in this case. Otherwise, it is wasted effort. So just changing the angle makes a big difference.
That brings to the next point. What is the standard toilet time, Vishwas? What is the standard toilet time one should sit in the toilet, and what is defined as standard toilet time? Because many patients, I have to sit long. Many actually parents complain the children sit long in the toilet, especially IBS
Actually,
patients.
you're not supposed to sit for more than 3 to 5 minutes. According to there's a very famous proctor surgeon in USA, he put this slide. You're not supposed to, one, you don't strain too much to pass stools, and you are not supposed to sit more than 3 to 5 minutes. And you should never have a diversion in the thing, like reading a paper or looking at your mobile or something. If you are not, if you evacuate once and you're not able to evacuate, you should come out, probably drink more water, do some physical activity, or sometimes you may get passage of stools after eating. And that thing you should take advantage of it. Don't ever, people come with a myth saying as soon as you eat and you go to toilet, you're not absorbing anything. That's not true. So you need to tell them that don't sit and strain for too long in the stools. Ideal time is only 3 to 5 minutes, not even 3 to 5 minutes. Actually, that's what he
I think the best time to defecate is within 1 hour after waking up. That's the time when you have got a large amplitude contractions of the colon, and along with that, if we take some drinks and walk up and down and all, things may move. So I was toiling with this idea of what is the normal toilet time for the last 4 years, and I was planned a study and it could not complete. But last month I completed a survey of 1,600 people with the help of our interns and other things, and the results are interesting. 40% of patients actually require only 5 minutes. About another 42% actually require 10 minutes, and 8% will require 15 minutes. So actually within the first 15 minutes, about 90% or 92% people are able to defecate properly. So 40% 5 minutes, another 40% 10 minutes, and 8% is 15 minutes. That's what we found out. We are writing it up along with the transit in normal people. Okay, I think that was a good presentation, Vishwas. I think you have covered everything. Everything was covered. That is a good presentation. And shall we close the session? Any further points?
Okay. Thank you.
Thank you.
Thank you, madam.
Good night.
Thank you, sir.
Thank
you,
you.
ma'am.
Thanks, ma'am, for joining us.
Thank you. Thank you.
We'll end the session now. The next class will be on Tuesday again. Okay. I am closing the session.